To Pediatric Grand Rounds. Today's speaker is Dr. John BIRKNES, who joined MMP Neurosurgery and Spine this past summer. Dr. BIRKNES is a graduate of Williams, where he was captain and quarterback of the Eafs. He then went to Jefferson for medical school and stayed there for surgery and neurosurgical training. He went on to do a fellowship in pediatric neurosurgery at the Children's Hospital of Philadelphia, and then further fellowship training at the Shriners in Philadelphia. He was most recently at the Children's Hospital of the King's Daughter in Virginia prior to coming to Maine. Today, scoliosis. Good morning and thank you for joining us.
All right, hello everybody. Well, Carol, thanks for the introduction. I was just about to give all that background myself, but down in Virginia, I did start a combined spinal deformity / scoliosis program that hopefully we're going to start to bring something like that or develop something like that here. As you all know, Phil Anson has been the main scoliosis guy. And I'm currently working with him, and that transition is going to happen. And hopefully we're going to get another deformity surgeon in here so that as Phil enters his retirement, we can still have that sort of dual surgery or dual surgeon scenario. Today, what I wanted to do was talk about scoliosis. I have, just so you guys understand, I have trained in scoliosis and spine deformity at Shriners and have done that for the last 12 years. It is that in pediatrics and pediatricians, mainly when they think about scoliosis, think about orthopedics, but that is starting to change more and more. There is more and more of a presence at the national meetings in the pediatric side of scoliosis of neurosurgeons being involved. So that is in process and in a transition. I've given this talk before COVID, and I like to keep it kind of informal. I would oftentimes have people raise their hand at the end of a slide or at the end of a section. Unfortunately, I think with the logistics, how they are here, that is going to be a little too cumbersome. So if we could just wait for any questions to the end of the talk, that would be great. Also, in the past, I've kind of taken my spine and shown sort of physically what happens with the spine. And so periodically, a couple of different times, what we'll try and do is unshare the screen and then be able to show you a little bit perhaps of what's happening in the spine itself with some of these deformities. So why don't I share the screen and we can start. All right. All right, so here we are. So, all right, there we go. So I was told to give you the text attendance for your CME credits on the first and last slide. So that's it, 72766. So for this slide, before we even start, one thing I like to do is separate or differentiate adult scoliosis and pediatric scoliosis. Adult scoliosis is very different from pediatrics. Essentially, it's the end game of degenerative spine disease. So the spine, the facets wear out, the discs wear out, and eventually the spine just kind of crumbles under its own weight. It's a much more, it's a much different animal to deal with. It's a much more difficult animal to deal with in the sense of you have poor bone quality, you have a much more elderly population. The protoplasm is not nearly as good and not nearly as reactive and recoverable as in the kids, or most of the kids at least. But we're all in pediatrics, so let's talk about the pediatric scoliosis. There are three main types. The last one is the one that I think most people deal with on a more regular basis, and that's idiopathic scoliosis. But we'll talk about the two prior ones before we get to that, and that's congenital scoliosis, which just means that it's a perturbation. You're born with that type of scoliosis. The spine itself has a problem with formation, and we'll talk about that. Next one is neuromuscular, and it's a very self-explanatory problem with the nerves or the muscles that are the nerves going to the muscles or the muscles themselves that help control the spine. And then idiopathic. And then we'll talk about a screening exam that most of you do or know how to do on a regular basis, but maybe some details in there that that can be helpful. And then how do you work these patients up, and what are some red flags to look out for that may not be sort of straightforward idiopathic scoliosis. And then finally, sort of how to follow these patients and when to refer. It's not wrong at all that you find scoliosis and refer it, but there are some pediatric practices that feel very comfortable and like to manage these patients before they absolutely need to be referred to a spine surgeon. And so we can talk about different ways and how to follow those, and when to feel comfortable and when maybe you should just refer. And it's always fine to call or email or text too, to find out, okay, what's going on with this patient. So before we even get to the different types, let's talk, how do we define pediatric scoliosis or pediatric deformity? Well, it's defined as a deformity in the coronal plane of 10 degrees or more. As we'll see in another slide down the road, there are a lot of curves that are less than 10 degrees. A lot of us are walking around with a small curve, 5 degrees, 7 degrees, whatever it might be, that doesn't quite reach the degree of scoliosis. So it's really the cutoff is 10 degrees or more in the coronal plane. And then how do you measure that, or how do you describe that curve? There are three main components to describing a curve, such that if you were to tell me over the phone a curve and you give me those three components, I can envision in my head exactly what's going on. So for instance, the first thing is, what side is the curve bending towards, or what side is the convexity? So in this case, this is the right side. So this curve is a right-sided curve bending towards the right. This is another right-sided curve over here bending towards the right. The next one is, okay, what are the limits of the curve itself? Basically, which of the vertebra is most angled at the top of the curve and which of the vertebra is most angled at the bottom of the curve. And that's how you actually go ahead and measure these Cobb angles, these degrees of curvature. So oftentimes you'll measure a couple different vertebrae to get the largest degree of curvature. So what you do is take that vertebra that you think has the most degree or the biggest angle to it on the superior aspect, and you take that superior end plate and draw a line that is parallel to that superior end plate. And then at the inferior vertebra, draw a line from that inferior end plate. Used to be that you would have to draw these lines on the film themselves. When I first started, that's how old I am. Nowadays, it's just all on the computer, and you can just draw these lines and come up with your degree of curvature. And it's that level at the top and that level at the bottom that is the final key. So it's a right-sided curve. If I were to describe this curve, a right-sided curve from T8 to L3 of 55 degrees. So if someone says that to me, immediately I can see what that is in my head. The other thing to understand is that when you're measuring those curves, I can measure it one day and then measure it the next day, and my line might be off ever so slightly at the top or at the bottom. So really within 2 or 3 degrees of a change is considered just that inter-observer or or the time between your measurements, that is just your margin of error. So if you have someone that comes in with an 18-degree curve, 3 months later they come back and they have a 20-degree curve, that's not really considered progression per se. That's just maybe the angle of the film that it was taken at, or maybe your measurements that you made that day. So that's important to kind of understand. Let's go on. So this is congenital scoliosis. So congenital scoliosis is the scoliosis that you're born with. And what that is that there is some type of perturbation in the development of the bones of the spine early on in development in the fetus. And there are 2 types of perturbations that can occur. There can be a defect in the formation of the vertebra. So this is an X-ray that has a good example of both of those cases. You can see on here, there's a little kind of wedge of bone over here, and this is a wedge of bone as well, not quite as severe as some that you'll see, but that's the defect in formation where one side of the vertebra formed completely and the other side did not. Over here, you can see this is a defect in segmentation. So this white line is where this vertebra and the one below it never fit, did not separate, did not segment out. And you can see that that even extends to the rib that's fused there as well. So that dark line. So this side is fused and will not grow. One of the key things to understand about congenital scoliosis is that you're going to get curve progression or progression of the scoliosis because you have growth plates over here and no growth plates over there. So this side will grow, that side will not. And so treating this with a brace really doesn't help or doesn't change the progression or of the curve or likely progression of the curve. This is a really good cartoon or caricature of what we're seeing. These are defects of formation where you have a wedge or what's oftentimes referred to as a hemivertebra. This is not quite so bad as a hemivertebra, but here you can see how it can almost not completely form or incompletely form on one side and completely form on the other. What you can see is that this causes a pretty acute change in the spine and an acute curve. You'll see this in stark contrast to our neuromuscular scoliosis types. Over here, you can see a defect in segmentation. If it happens on both sides, you get what's called a blocked vertebra, and that's not really going to cause you too much of a problem in deformity. Over here, you can see where you have the defect in segmentation and a fusion bar over here. Here you have a combination of the two. This is the most likely scenario that's going to progress and keep progressing, and you need to watch this type of scenario very closely because that may progress to the point where you need to intervene surgically. We've talked about this. The bracing really has no effect. This is a very good example of an X-ray with that hemivertebra. And here's a 3D CT rendering of that. Oftentimes, it not only causes a defect here, but it also is more of a wedge posteriorly versus anteriorly and causes a bit of a kyphosis or bending forward at that level as well. Last thing to remember about congenital scoliosis is that since there was a perturbation in the development of the spine, also other organ systems that are at a crucial development time period can be affected as well at that time. And so it's imperative or dependent upon you as the treating physician and myself, because these are so rare. Basically, if you see somebody that has congenital scoliosis, you should just refer them to a spine surgeon. But it really is dependent on me to figure out and make sure that none of these other organ systems are involved. And those are basically the neurologic system, cardiovascular system, and the GU system. So here we need to get an MRI of the spine to make sure that there's no underlying pathology, syrinx, sometimes diastematomyelin. Also make sure there's no cardiac defects. A lot of these kids will have a concomitant cardiac defect, or also an ultrasound of the kidneys and the GU system to make sure that that's not involved as well. Sometimes the MRI of the spine can include that renal system, and so you don't necessarily need that. But for completeness sake, I usually do that. And about 60% of the patients will have some other defect going on. Doesn't always need to be addressed, but certainly you should go looking for it to make sure it does not. So neuromuscular scoliosis, like we spoke about earlier, this is where the nerves going to the muscles of the spine or the muscles themselves are not quite either strong enough or asymmetric, in the sense that the spine ultimately ends up kind of falling under its own weight. This is seen in spinal cord injury. A lot of our cerebral palsy patients will have this. A lot of the spina bifida patients have this. Anyone with muscular dystrophy can have this. Let me see. Let me unshare for 1 second. And All right, can everyone see me okay here? So essentially what I wanted to point out here is that when you're looking at a congenital scoliosis, it's almost as though you were to take the spine and put a wedge in it. And so you have a very acute change in the spine. The rest of the spine can oftentimes adjust, and you'll get a curve here and a curve below it in order to keep things balanced. In neuromuscular scoliosis, though, it's the exact opposite, where that's a very acute change in the curve. In the neuromuscular, you get this long kind of C-shaped curve, as you could imagine, just the spine kind of just crumbling or deforming under the total weight. And so it's not any one particular spot, it's just the muscles of the spine or the nerves to those muscles can't really support the overall weight. What you end up with is actually a lot of pelvic obliquity. A lot of these guys are wheelchair bound, and that pelvic obliquity and that long C-shaped curve cause a lot of the difficulties that we'll see in those patients. So that pelvic obliquity can cause poor sitting. And what you end up with is when these kids are sitting in one wheelchair, they're sitting really on just one of those ischial tuberosities. A lot of times the wheelchair clinic can adjust the seating so they can get as balanced as possible, but at some point you can reach an obliquity that you really can't do that, and you can end up with these decubitus ulcers that need to be oftentimes, debrided, vac wounds placed on them. And when that starts happening, that's one reason to really go ahead and do the surgery. You also, when you get that significant pelvic obliquity and that long C-shaped curve, you can get the ribs that end up sitting on the iliac crest, and that can be bone on bone type of pain and cause significant pain. And once you get these serious curves up to 70 degrees and more, you can start to impact the GI system. And if the apex of the curve is high enough, definitely starts to impact the respiratory system. These kids are some of the more, not the most robust kids. And the surgery to fix that is a really big surgery. So we oftentimes will wait until it's absolutely an indication. Oftentimes we'll try and maximize their nutrition, sometimes even put a G-tube in if their nutrition is so low, and really try and get them to a point where they can get through those surgeries when they need it. And we try and choose them very closely, because when I talk to these parents, I say, it's not a matter of what type of, hurdle in the road to recovery we're going to have. It's not if there will be one, but it's which one and how quickly they recover from it. So it's something that everyone needs to be all in. That being said, a lot of these parents have had a lot of difficulty with moving the patients, with caring for the patients. And when we really get a good correction and get them much more stable, the kids sit in their chair much better. They're happier, they're more upright, the parents are able to move them, and they can be some of the more satisfied parents that we deal with. This slide really just goes to show that with spinal cord injury in particular, that the progression for the spinal cord injured patient, a pediatric patient in particular, is very dependent on growth. So you have the young kid, the 0 to 10-year-old that has a spinal cord injury. Just about every single one of those, as they go through their adolescent growth spurt, their curve is going to progress significantly, and they're very likely to need surgery. As they get older, you can see that if they don't have a ton of growth left, then it's much more likely to progress to that point of needing surgery. One thing to know about neuromuscular patients is that early on, when I was in training, it actually was said there wasn't a role for bracing. There's been more and more literature that's come out since then that said, if you find these early on and you institute a brace, you can at the very least delay surgery until they're older, but oftentimes you can even prevent it. And so there is a role if you catch these kids when these curves are small enough to go ahead and intervene with a brace. So idiopathic scoliosis. This is the a third type of scoliosis that most of you are very familiar with, that you do your screening for, your Adams forward bending test, all that stuff. But even among idiopathic scoliosis, which just means we don't know what causes it exactly, there are three sub compartments to that. You guys know about the adolescent idiopathic scoliosis, but there's infantile and juvenile idiopathic scoliosis. Those are actually more diagnoses of exclusion. A lot of times, if you find a child that's much before the adolescent growth spurt and they have scoliosis, that's pretty rare. And it's oftentimes, most people will say, get an MRI to make sure that there's not some underlying cause for that scoliosis. So it's not infrequent that we'll see somebody who has a scoliosis and either it's really early on or it's an unusual curve pattern. We'll get this MRI and we'll find a syrinx, and then we'll also find a Chiari malformation that's causing the syrinx. That's one of the few scenarios where you can actually intervene and reverse scoliosis. So if you get that in a child that still has a good bit of growth left and the curve is small enough, if you fix the Chiari malformation and the syrinx goes away, and the syrinx is what's causing the scoliosis most of the time when you see that scenario, then you actually will halt the progression of the scoliosis, and you even can get reversal of it with time. So, so it is important to kind of understand when you need to question, is this a idiopathic scoliosis or is there some underlying lesion that could be causing that? And if they're in their adolescence and they have certain curve types, in particular right-sided thoracic curves or left-sided thoracolumbar curves, those are the classic curve patterns for adolescent idiopathic scoliosis. And so if you see, that 12-year-old girl who 2 months ago had her onset of menses, she's grown 1.5 inches in the last 6 months, and she has this right-sided thoracic curve, meaning like what we're seeing here, the curve is pretty much entirely in the thoracic spine, curving to the right side. You see that in that scenario, no need to dig any deeper. It's pretty certain she has adolescent idiopathic scoliosis. Do a neurologic exam and then follow her, as we'll talk about. The other curve is a left thoracolumbar curve. This is not that, but the major curve, the big curve, is down here, and the apex of the curve is either at T12 or L1 or the disc between. That's what we mean by thoracolumbar, is that the apex of the curve is at that thoracolumbar juncture. And that's the other normal curve for adolescent idiopathic scoliosis. If you see children younger than their adolescents and they have any type of significant scoliosis, then they really deserve an MRI to make sure there's not an underlying lesion. All right. Now, as we were talking about before, the prevalence of curves is much bigger when you get a smaller curve. So curves of 5 degrees or less, you can see there's a good number of us out there, 14%, that have that. Interestingly, the female to male ratio is much closer to 1:1. As we get up to real scoliosis, you can see that, yeah, that percentage of people that really have scoliosis is lower now. And that female to male ratio is higher as well. And then once you get to anything significant, talking about bracing and things like that, you can see there's a much lower percentage of kids that have that. And that ratio now is 10:1 in females. Good question. Why is it female to male ratio? No one really knows. There are some theories out there. The one that I kind of like the most is that females tend to grow very rapidly during that adolescent growth spurt. That's why, when you're at the 8th grade dance, the girl's up there, and then by the time you're at your senior prom, the boys have caught up and they're the opposite direction. And it's that very rapid growth that tends to cause scoliosis to progress significantly. So the common story, as you all know, is that yeah, we didn't notice it this past summer. And then she grew 3 inches and it's February. And now she's got this 30-degree curve and we have no idea. Did we miss something? What happened? And it's just that they grew so quickly that the curve just took off. So what does cause this idiopathic scoliosis? We don't really know. We do know that genetics absolutely plays a role, that if you are a daughter of a mother who has scoliosis, about 1 in 4, 27% of those daughters will have scoliosis. The one statistic that I think is really telling is great is that monozygotic twins. So you have identical twins, one has scoliosis, not 100% of them will have scoliosis. So it's not 100% concordance, but 70% will. So there's obviously some genetics at play, but then also some environmental factors that must be at play as well. It's interesting, about 10 years ago, pretty soon after I got out of fellowship, there was a big push and a big marketing campaign from one of these big spine companies about what was known as the scoliosis score, which you could get a saliva test, you could get a genetic test, and they had come up with this slew of genes, some of which would, in the scoliosis patient, some of which would protect you from progression, and some of which were supposed to be markers of progression. And they would come up with the scoliosis score. They marketed it really strongly. A lot of us adopted it and started using it. And then as we started to use it, we started to notice that actually, it didn't work at all. And it pretty quickly, within 2 or 3 years, completely fell out of favor. There was a lot of real positive thinking that, oh, this is going to be a real game changer. We'll be able to tell patients, okay, you need the brace. You're not going to progress. The next person, you're not going to progress. You don't even need a brace. But that never panned out. And so we're still waiting for someone like that to come along. So you see a patient, you think they might have scoliosis. What do you want to do? Well, the first thing is take a history. First thing to understand is the age when it's first detected. So they come to you, they're 11 years old, they have a scoliosis, but they say, oh, no. When we were in Seattle 3 years ago, we had that scoliosis and our doctor told us that it would just go away. Well, 11 years old, you're thinking, okay, that's an adolescent, but if they had it at 8, well, maybe that's not an adolescent. Maybe we need to think, is there something else going on? Is there an underlying cause to that? Family history is important. We just talked about the genetics. So especially if you're talking about following these kids and counseling these parents, you have the 11-year-old with a small scoliosis, and there's no history at all to the family of scoliosis. Contrast that to the 11-year-old whose mother had scoliosis and had surgery for it. She had an aunt who had scoliosis, didn't need surgery. Her father's sister had scoliosis and she needed surgery. So if there's a lot of scoliosis in the family, then you need to be really kind of cognizant and weary or leery of the fact that this thing could progress, and you need to be on top of it and maybe a little bit more vigilant about following it, and a little bit more vigilant about advising the parents that this might progress. Next thing, any neurologic symptoms, so, oh yeah, no, I get this tingling in my feet, all the time, and it happened a year ago. Anything that's unusual like that. Scoliosis doesn't cause neurologic symptoms or signs. So anything that's going on neurologically, we need to think, is there some underlying cause of the scoliosis as well? Back pain. Scoliosis can cause back pain. If you think about it, if it's a significant enough curve, it causes some of the muscles to be out of their normal anatomic alignment, and certainly can cause some back pain. Usually the number I use is around 30 degrees or more. You might get some back pain. Much less than that, it's probably not the scoliosis that's causing the back pain. The good thing is that almost all of the scoliosis will respond, of the back pain that's associated with scoliosis alone or idiopathic scoliosis, will respond to physical therapy. Invariably, though, you send them physical therapy, pain gets better, and I see this in a lot of other kids too. Then they stop doing the physical therapy and the pain comes back. So they just need to keep doing that physical therapy, keep those muscles flexible, keep those muscles strong, and that should keep the back pain at bay. Last sort of thing to ask about is menses. That's important in females, because when you're thinking about, okay, what's going to happen with this curve, it's very dependent on how much rapid growth is left. And in girls, they tend to grow very rapidly, and that adolescent growth spurt tends to be centered around about 6 or 12 months before and 6 to 12 months after their very first period, after their onset of menses. So it's important to kind of find that out to get a good gauge or a guideline. Now, it's not 100%. You have to use some other factors to guide you in terms of, okay, how much growth do they have left? But that's one piece of information that is a good one to kind of follow and give you a signpost along the way of their progression to skeletal maturity. So the next thing is physical examination. So first thing is a thorough neurologic exam. They should be neurologically intact, no abnormal finding. If there is an abnormal finding, then we got to get an MRI and see, is there something underlying that? Then when you're looking at their back, what are you looking at? Well, I'm oftentimes looking at their shoulder heights, because a lot of times if you have a curve like this, what that does is drive that right shoulder higher than the left. That's a lot of times the first thing that the parents notice. They say, yeah, I tell them, why is one shoulder higher than the other? I didn't understand. And then I looked at their back and I said, whoa, what was going on? And then we talk about the scapular prominence, and that's forward bending test. And we'll actually, I'll unshare the screen and show you what where that's coming from in a minute. Truncal shift. So a lot of times what you'll find is in a curve like this is that their trunk up here is shifted over to the right side. And what you'll find is that on one side, when you're looking at their trunk, you're looking at their abdominal creases, you'll find a flattening of the crease on one side and an accentuation on the other, because that trunk is really shifted over. And that can, when it's bad enough and they need surgery, you oftentimes reverse that to the parents and to the child, is that redevelopment of those symmetric abdominal creases. Pelvic obliquity, you can see, so sometimes what you'll see is that a limb length discrepancy can cause one leg and one hemipelvis to be higher than the other. And if that's the case, then the takeoff of the spine is at an angle. And what the spine oftentimes does is just give a gentle curve to pull the head back in balance over the pelvis. So that's one thing to look at, is that sometimes you're kind of fooled that it's scoliosis, when really the scoliosis is just the spine's response to a pelvic obliquity secondary to limb length discrepancy. And that rib hump or that scapular prominence, that's the Adams forward bend test that we're talking about, that I think all of you are pretty familiar with. So I'm going to stop sharing just to kind of give a sense or show you what where that's coming from. So when we talk about scoliosis, right, we talked about scoliosis being a deformity in the coronal plane, in this plane of 10 degrees or more. So the normal, but scoliosis is a deformity in all three planes. It's a three-dimensional deformity. What I like to say is that it takes the straight spine and makes it curved. But then what it also does is when you look at the spine in the sagittal plane, it should have these gentle curves in it. What the scoliosis does is it actually causes this curved spine to become straight. And so when you look at a lateral x-ray of a kid with scoliosis, with idiopathic scoliosis, there should be some straightening of that normal thoracic kyphosis that you see. That's a normal response. The last dimension that's affected, as you can see, if I do this, is this axial plane, and there's rotation. So what happens when you get this curve like this, you actually get the curve rotating like this as well. And so what you see is if you have ribs on this side, and there's even a small amount of rotation to the spine, those ribs flare up, and they do the opposite on the other side, so that when you have that patient that then bends over, right, you're seeing that scapular or that rib hump because of the rotational component of the. Okay. Hello. There we go. So that's what we're seeing on the Adams forward bend test. And you don't need to know what degree curvature. That's something that I'll oftentimes do and include just so you can get a sense for how much that corrects. Interestingly, if someone gets a bad enough scoliosis that you need to operate on, I talked to the patients about the 3 different dimensions, and we can treat the coronal the most. We get the most correction out of that coronal plane. The next most correction we can correct is that sagittal plane. And this axial plane is the most difficult to treat. And I oftentimes say that we'll probably reduce that rib hump by about 50%, kind of giving them some expectation that we really can't make it perfectly flat, but hopefully we can get about 50% correction in it. Interestingly, the one thing to understand is that that does not correlate. You know, certainly you would hope to think, okay, maybe we don't need x-rays, maybe we can just follow that Adams forward bend test, but that does not correlate to the degree of curvature. Scoliometer 10, you can see how significant it gets. So this is usually with a bigger curve, but oftentimes kids can hide that, or they don't have that amount of rotational deformity with the same amount of a coronal curve. You can see something like this when they're bending forward, and it's really too bad, because it would be nice to be able to just follow them with this with the Adams forward bend test and the scoliometer, but unfortunately it doesn't correlate to the degree of curvature per se. So here we are. We've taken a history. We think that based on physical exam, they have scoliosis. So what's the next step? Well, you get scoliosis x-rays. You look at those x-rays and they're adolescents. They have a right-sided thoracic curve, or they have that left-sided thoracolumbar curve, which are our normal adolescent idiopathic scoliosis patients. We just say, okay, they have AIS. All right, well, let's say it's not as straightforward as that. Well, who should get an MRI? And who, as part of their workup, should get an MRI? Well, those really youngsters, those kids that are not in the adolescent age. Now, 10 years is a bit of not entirely arbitrary, but not exactly straight on. You know, some girls get their period at 9, 9.5. So you have to kind of, that's not an absolute there. You have to kind of play with that a little bit depending on what your patient has or who they are. So if you have that juvenile or infantile scoliosis, you might think about getting an MRI. Anyone with an abnormal neurologic exam or neurologic findings or symptoms, anybody without these normal kind of curves, so that left thoracic or right thoracolumbar curves. And like we talked about, the kyphosis at the apex. So if they don't have that straightening of the spine, but rather hyperkyphotic at the spine, that might warrant getting an MRI as well. So let's talk about progression. When are we worried about these things progressing? The one thing to think about, females progress more often than males. It has to do with how much growth is left and how much rapid growth is left. So we'll talk about the Risser stage, how far off they are from their onset of menses. This is kind of just an average for females at 11.5. And then the curve magnitude as well is important, and sometimes the type as well. So the first thing to think about here is this Risser stage. The Risser stage was developed to tell you how far along someone is in terms of their skeletal maturity. So when someone is completely skeletally mature, there's a cap of cartilage on top of this iliac crest. What's nice about this score is that we almost always have this available to us with the scoliosis x-ray. So we can use this along with our scoliosis x-rays and get a sense for how far along they are in terms of their skeletal maturity. As they start to become skeletally mature and are getting through their adolescent growth spurt, that starts to ossify from the lateral aspect to the medial aspect. And we break that iliac crest into quarters. And if that ossification is in that first quarter, there's a stage 1, 2nd, 3rd, 4th. And then, as you can see, there's sort of a line between the cap and the iliac crest itself. Once that really fills in, that's a stage 5. So down here on this x-ray, you can see that cap of bone, and it's over here in that 4th quarter. There still is that line there. So this would be a stage 4. Here's an excellent study and a good kind of example to show you the degree of curvature and skeletally immature. So Risser 0 or 1, very skeletally mature, significant curve or a bigger curve. There's a 2/3 of those kids are going to progress. Now you have a small curve. You have someone who's more skeletally mature, and you can see how much lower their percentage of progression is. So that's something to kind of think about as you're dealing with these kids and thinking about what is their risk of progression, how frequently should we follow them. So outcomes into adulthood, I talk about this with just about every scoliosis patient, and that is that if our goal of dealing with these kids with smaller curves is to get them through their adolescent growth spurt, to get them to skeletal maturity and keep their curve less than 30 degrees. If we can keep that curve less than 30 degrees and they're skeletally mature, very, very, very good chance that that curve is going to not progress and they're going to stay there, kind of say, hey, have a good life, call me if you have any problems, you're good to go. The other end of the spectrum, the curves that are 50 degrees or more, regardless of whether you're at skeletal maturity or not, we know that those curves are going to progress. And the further away from 50 degrees, 60 degrees, 70 degrees, the more likely they're going to progress, and usually the more quickly they are. And those are the curves that we tend to start talking about and recommending surgery to. Obviously, there's that gray area between 30 and 50 degrees. Especially with the lower degree patients, there's probably no difference in back pain between the general population. We talked about this a little bit with the neuromuscular guys, is that pulmonary function. Once you get up to 70, 80, especially above that, you really start to see impacts in the pulmonary function. Pregnancy probably has no effect. So there used to be some question that when I'm pregnant, is my scoliosis going to get worse? Looks like that's not going to happen. So what's your treatment for scoliosis, for idiopathic scoliosis? Well, for conservative treatment, there's observation, there's physical therapy. There has been electrical stimulation that's been tried, trying to stimulate the muscles on one side, doesn't seem to work. And then there's bracing. And then there's surgery, there's spine fusion. And then experimentally, there actually is some fusionless ideas out there that are being investigated. It's not really FDA approved at this point. It's still in its experimental phases. So let's talk about observation and how to deal with these kids. So curves that are less than 25 degrees. So an absolute curve, kid comes to you, 18 degrees. All right, we're going to observe you. The question is, okay, how frequently are we going to observe you? So this is an 18-year-old with an 18-degree curve who, everything else falls into line. It's discovered simply randomly or incidentally. You say, you know what, maybe we'll get another x-ray in a couple of years. You're 6 years post-menarchal. It's such a small curve. We'll get another x-ray just to make sure, but really don't worry about it. That's in stark contrast to that 11-year-old that just had their period with a rapid growth, Risser grade 0, 18-degree curve. You probably want to check that x-ray again in 3 or 4 months, because the other, the next thing we're going to talk about is bracing. And if that curve progresses 5 degrees or more, then that's an indication for bracing, or an absolute curve of 25 degrees. And so that's our next slide, talking about bracing. So curves, absolute curves that are 25 up to 45 degrees should start bracing. Just if they walk in your door. I had one yesterday, came in with a 33-degree curve, set him up to go get the brace fit. measured and fabricated and then fit in a week or two once they make the brace. So that's kind of straightforward. If this, then that. The other is progression of greater than 5 degrees. So that 11-year-old that came in with 17, 18-degree curve comes back in 3 or 4 months and now has a 23-degree curve. Well, it's not 25 degrees yet, but it is a 5 degrees of progression. Start bracing at that point. Physical therapy certainly doesn't hurt. Over in Europe, there is something called the Schroth method that is very popular. That's more and more popular over here in the States as well. On it, I lean more towards the side of it might do something. It certainly doesn't hurt, and certainly with the right parent, it makes them feel like they're doing something. So that's certainly an option in terms of the conservative management. Electrical stimulation really is not panned out too much to be effective, so don't really use that, or I don't at least. Bracing. There was, when I was training, there was some mixed literature still out there. Most people still felt like bracing was absolute. And then in the, about 7 years ago, this study came out, which was randomized prospective. It kind of closed the book on it. Absolutely. You can see that with the brace, 25% progressed. Without the brace, 60% progressed. So an absolute efficacy. I say that when I talk to parents, I say there's absolute efficacy. Now, it doesn't work for everybody every time, but I cite this study. It was actually stopped early because of the efficacy of the brace. There are different types of brace. The type that I like is this one. This is called a Boston brace. You wear it pretty much as possible, up to 20 to 22 hours a day. Take it off for showering, take it off for any sports activities, but wear it pretty much all the other times. Surgery is reserved for curves greater than 50 degrees. If you have someone that's at 50 degrees, they're done growing, there's a balanced curve, someone around there, you might say, hey, let's watch it, depending on how averse to surgery are, how much their body image is bothering them, those sorts of things. So it's never an absolute, but it's, much above 50 degrees, you got to really start talking about it. We talked about significant pulmonary compromise at 80 or 90 degrees. Pre-op, you can see, post-op here. I wasn't going to get out of this talk without showing you some post-op x-rays. So summary, talked about the 3 types of scoliosis: congenital, neuromuscular. These are both pretty rare. So if you see these, you can just refer those on to a spine surgeon. Some of these neuromusculars are already being followed, though, at a spina bifida clinic or something like that, or a spasticity clinic might already be following them for their scoliosis. So just make sure that somebody's not already following them for that. Congenital is from malformation of the vertebra. High incidence of associated anomalies. You don't necessarily need to worry about that if you just refer all these. They're very rare. So if you see someone with a hemivertebra or something like that, just refer them to a spine surgeon. Neuromuscular, most of them are non-ambulatory. Early bracing may prevent or delay. Idiopathic scoliosis, the age and skeletal maturity is going to tell you. And the curve type is going to tell you whether you need an MRI or not. So those right-sided thoracic, those left-sided thoracolumbar curves in those adolescents with a normal neurologic exam, just adolescent idiopathic scoliosis, those are the majority of what you'll see. But those that deviate from that really might need an MRI. Bracing is the mainstay of treatment for conservative treatment with these kids, plus minus PT. We talked about the surgery for 50 degrees or more. This vertebral body tethering, we can talk about that afterwards if anybody's interested in talking about that, as perhaps some in special cases in the future that might be a possibility. Screening exam, looking at the shoulder heights, trunk shift, pelvic obliquity, Adams forward bending test. And so here's kind of a nice little summary of when to refer, when not to refer, kind of an idea. So if you feel like, okay, I find a scoliosis, I send it to the spine surgeon, that is fine as well. This is really if, okay, my practice wants to start to do some scoliosis, or they do. when should we feel comfortable? Well, if you find, those kids with those right-sided thoracic curves, left-sided thoracolumbar curves, I think I'm stressing that with those low degrees of curvature, should feel comfortable doing that. Depending on your comfort level, once they get up to closer to 20 degrees, with those normal curves, that's okay. Once they get above 20 degrees, close to that 25 degrees, where we're thinking, okay, we may have to start talking about bracing or instituting bracing, get those to the spine surgeon, because they're the ones that are going to be dealing with the brace and talking to them about the brace and how to wear the brace, how often to get x-rays after that and whatnot. And then, so if you're going to follow them before the brace comes into play, how often? Well, that's going to take into, you're going to take into effect where they are in terms of skeletal maturity. So listen to where is their menses, how far out are they? Did they just start their period? Are they 2 years out, 3 years out from their period? Different scenario. What's their Risser score? Is that whole cap completely fused and they're skeletally mature? What's their degree of curvature? So kind of two ends of the spectrum. You have that girl that's skeletally immature, just started her period, 23 degrees curve. Do we send her? Don't we send her? Well, certainly if you feel comfortable, that's fine. But the thing is, get another x-ray, because she's, in that adolescent growth spurt with a good size curve. Get another x-ray in 3 or 4 months, make sure that she's not progressing. The other end of the spectrum, that 15-year-old that is 3 years post-menarchal, Risser 5, 18-degree curve, that's someone that you say, hey, you know what, you're really outside that worry zone of rapid growth. You have a small curve. We could probably wait a year or two and get an x-ray. And if that's good, you're good to go. And then somewhere between there, you just have to use good judgment. So when do you refer? Well, curves that are approaching 25 degrees, like we spoke about, curve progression of 5 degrees. So anybody that's looking at a brace, less than 10 years old, do they need an MRI? Don't they need an MRI? Where do we stand? Those congenital and neuromusculars, those ones with the left-sided convex curves of the thoracic curve, or those right-sided thoracolumbar, those unusual curves that aren't straightforward idiopathic scoliosis. Any abnormal neurologic exam as well, you can go ahead and refer. Also, any questions, you can refer or just call me as well, or message me through Epic. Now that I know Epic, because I didn't have Epic at my previous job. But more importantly, thank you very much. What I did want to tell you was give you my cell phone number. So, text or call me if you have any questions on anything. Say, I saw this guy, he's got an x-ray. Can you look at it? Let me know what you think. Or give me a call back when you have a chance. Anything like that. I want to be very available to help manage these kids. If you feel like just referring them, just refer them as well. And here again is the text attendance. So thank you very much. Hopefully I didn't go over time too much. And I'm happy to take some questions.
Okay, so there are a few questions in the Q&A in the chat. So the first one is the AAOS, SRS, POSNA, and AAP believe that screening exams for spine deformity should be part of the medical home preventative services visit for females at age 10 and 12 and males once at age 13 or 14. The question is, it seems like this may be too late for potential intervention. Why is the recommendation to not screen until females are close to or past menarche?
Well, it didn't say females 10 to 12.
Yes.
Yeah. So when I think about the onset of menses for females, I think of that as being average around 11 or 12 years old. Maybe I'm wrong. I have seen a couple of kids that have their menarche at 9 years, when they're between 9 and 10 years old, but they're more of the outliers. So I think they're trying to get you at that 10-year-old time frame, before that onset of menses. But certainly you can start earlier if you think that that's warranted. It doesn't hurt to bend them over in the office and look at their back and look at their shoulders. So.
Okay. The next one is, can you talk about the complications of spine fusion? How does it change function, pain in the long term?
Oh, very good question. Excellent question. So The one thing I will say, it really depends on where you're fusing and how much you're fusing and what levels you're fusing. I always talk to the families with the thoracic spine. So I'll do this again. When you have when you just have a thoracic curve. So a lot of kids will have a thoracic curve, but you never have just the thoracic curve. You'll oftentimes have this compensatory lumbar curve. And what that does is bring the head back in balance over your pelvis. There are all kinds of measurements and guidelines depending on how flexible this lumbar curve is, but a lot of the times you're able to just fuse that thoracic spine, and this lumbar curve will just correct itself and get things back in balance. If you're able to just fuse the thoracic spine, that is really great for the child, because your thoracic spine really doesn't have much mobility in itself. It's attached to this rib cage that then attaches to this solid piece of bone, the sternum in the front. So you do have mobility in the thoracic spine, but not nearly as much as you do in the lumbar spine. So kids that just have a thoracic fusion, a selective thoracic fusion, ultimately don't lose or feel like they lose a whole lot of their mobility. Now, depending on how far down the curves are and some of those thoracolumbar curves that we talked about, if you have to go down further into the lumbar spine, then you are taking motion segments away. And then you do need to talk about with the parents, the fact that you're leaving motion segments behind, maybe 3, maybe 4, maybe only 2 motion segments behind that otherwise would have been distributed over 6, 7 more levels. And there is a known increase in the degeneration of those discs. I always say, you know, if you were going to have problems and disc herniations when you were 50 or 60, maybe we're looking at 40 or 50 instead. I also then will advise them that, you know what, though, the best thing you can do after this fusion is to stay nice and trim and have a very strong and flexible core. So I will talk to them about getting into physical therapy, getting into yoga, getting into Pilates, getting into any number of things after surgery, 6 months usually after surgery, that's going to work their core and their back muscles and keep them strong and flexible and trim, so they help support those few levels below. I hope that answered it. There are a lot more risks with this that go through the surgery itself, but I think based on that question, I think you were asking long-term down the road after the fusion, what do they need to worry about?
Okay, and I think just one more quick question. For routine screening in children with CP, how many views would you want to have to review?
For routine, just AP and lateral. And that's interesting. One thing that I didn't put there is, and I don't know that we'll get it here at this point, but oftentimes what we'll get is a PA view rather than an AP, because of that rotation of the spine. If someone stands, when you get an AP, they stand with their back against the film. And what happens is if they stand with their back against the film and they have that rib hump, their spine will rotate and you're not getting a true straight on x-ray. So there's much less of a deformity to the front part. So oftentimes we'll ask them to do a PA where they'll stand with their chest against the film itself and shoot from the back to the front. It's hard to kind of get the x-ray text to read into that and understand why we're doing that. So oftentimes we don't get that, but that's a little side detail that hopefully if we can get a big program up and running here, maybe in a few years, we can start to get PAs instead of APs and lateral. But it's a minor detail, but it's 2 views, AP and lateral.
Okay, so thank you very much. I think we have to stop here. There are a few remaining questions, and maybe people could chat them to you or email you.
Yeah.
Okay, great. So thanks again, and we will stop there.